Good afternoon, colleagues. It is a lecture about the pelvis and spine trauma, and we will start from the fractures of the spine. Before we'll talk about classifications, clinical picture, let's try to remember the basic anatomy of the spine, and related to that anatomy, a few concepts of the supporting elements and supporting columns. As you can see here, we have so-called three supporting columns concept provided by Dennis. And in that concept, we have anterior, middle, and posterior column. The anterior column represented by anterior two-third. Let's take a look here. Anterior column represented by the anterior part of the vertebral body and anterior part of the intervertebral disc. But it shouldn't be half, as you can see here. It is around two-thirds. If you will split the body for three parts, three absolutely same parts. What anterior two parts, it will be anterior supporting column, as well as the anterior two-thirds of the intervertebral disc, plus ligament, which is cover the anterior surface of the vertebral bodies, which we call anterior longitudinal ligament. Middle column, as you can see here, represented by posterior one-third of the bodies, posterior one-third of intervertebral disc, and posterior longitudinal ligament. And finally, posterior supporting column, that is a facet joint in between the vertebrae. It is a ligamentum flavum, which is located in between the arcs of the vertebrae. Then that's the spinous processes together with the intraspinatus ligament. Transverse processes together with the ligamentum intertransversum. So all supporting elements, facet joints, ligaments, which are located posterior to the posterior longitudinal ligament. So, what is the main idea? Why Dennis split the spine for three supporting elements? Initially, he just tried to explain how the forces which we have in the spine split it or transferred in the different anatomical parts. For example, he found out that the axial compression forces, most common forces which we have in our spine, in general absorbed by vertebral bodies and intervertebral disc, and only 20% from those forces goes backward to the facet joint and ligaments of the posterior supporting complex. That's why he split the spine into anterior and posterior complex. Another type of the force, like distractive force or extension forces, overload the posterior elements. So 80% of the distraction forces will be located in the area of the facet joint and ligaments, which are located around, and only 20% will be located in between the vertebral bodies and intervertebral disc. So, if we knew how the different types of the loading spread it inside the vertebrae, inside the different anatomical elements of the spine, we can expect the different types of the fractures. And we have so-called McAfee classification, where we have explanation what type of injury we should expect in case of different mechanical traumas, different mechanism of the traumas. And the first type of the fracture which we should expect, it is so-called wedge compression fracture. The X-ray findings you can see here on the right side. As you can see, during the X-ray examination, you can find anterior compression of the vertebral body. So anterior height of the vertebral body become less than posterior one. The reason, the etiology of compression fracture, it is falling from the height or hyperflexion. So it is compression mechanism fracture. Compression mechanism fracture. Let's say that it is the most common type of injury if you will talk about general statistic of the spine trauma, spine injuries. Compression fracture, that is the number one. Fracture. And we can split that type of injury for three types as well. It can be grade 1, grade 2, and grade 3 injury. Grade 1 injury, it is a condition when the anterior height of the vertebra become less compared to the posterior, less than on 1/3. In between 1/3 and half, it is a second grade compression. And if the anterior height of the vertebra decrease more than on 1/2 compared to the posterior, we call it compression fracture grade 3. If you talk about the complications, as you understand, in case of wedge compression fractures, we shouldn't, in most cases, we will not see any neurological deficitis. Second type of injury, it is so-called stable burst fracture. Difference, if you will compare the first type and the second one, difference, it is a condition of the vertebral body. For the burst fractures, we have comminuted injury. We have a few bone fragments at the area of vertebral body. The mechanism absolutely the same. It is axial compression or hyperflexion, but the force which is applied is much more severe compared to the first injury. And in result of that overloading, we have a splitting of the vertebral bodies for few fragments. Why both fractures are stable? Because in both cases, the posterior supporting column still stable. In both cases, we have injury only of the vertebral body. And if you have injury only of the anterior column isolated, or if you have isolated injury of the posterior column but anterior still intact, in that case we are talking about the stable injuries of the spine. Here you can see example of the unstable fracture. Unstable fracture, it is a condition when we have injury of the both anterior and posterior supporting columns. Here you can see example of the unstable burst fracture. Mechanism is the same. It can be axial compression, but in most cases it is combined with lateral flexion or rotation. So if patient, for example, fell down from the roof or from the second floor, third floor, and during the landing, together with the axial forces, compression forces, patient had some rotation or lateral bending. In that case, you can expect injury of the anterior and posterior supporting elements. And in that case, we are talking about unstable injury. And if you have unstable injury, we have direct indication for surgical treatment. And one more thing, of course, in that case, in case of unstable burst fractures, risk of neurological complications is very, very high. Another very rare fracture, which you can see, it is chance fracture. In that case, we have horizontal line, which is split, horizontal line of the fracture, which is split vertebra for two parts. We have superior part, proximal part, and distal part, inferior. Usually, the mechanism of the trauma, it is a car accident. When the car hit the person from the front or from the back, and the direction of the forces transmission will be horizontal, from the back to front or from the front to back. A very rare injury, as I said before, and it is example of unstable, quite commonly complicated fracture. Another type of injury, it is so-called flexion distraction injuries. From the name of that fracture, you understand that it is a condition when we have a combination of flexion and distraction at the same time. Not very common mechanism, once again, but possible. And in that case, quite commonly you see injury of the intervertebral disc, which is combined with facet joint injury and posterior longitudinal ligament injury. As I said before, from the Dennis supporting column theory, we knew that if you have distraction forces, most of the loading will be absorbed by the posterior supporting elements, such as facet joint, intraspinatum ligament, supraspinatum ligaments. And in that case, you will see fractures of those elements plus, or injuries of those elements plus possible injury of the intervertebral disc. It is unstable injury, as you understand, because both anterior and posterior complexes, supporting complexes, become damaged, and risk of neurological complications in that case is very high as well. Translational injuries, quite similar if you talk about the mechanism of the trauma, with chance fracture, and for that trauma all three supporting columns become damaged. Mechanism of the trauma, it is heat, high energy trauma, car accident, heat from the back or front, plus usually that force combined with the flexion or extension. So the line of the fracture not pass through the vertebra alone. The line of the fracture pass through the vertebral body, facet joint, ligaments, sometimes through the intervertebral disc. But so the main difference compared to the chance fracture, that the line of the fracture involves some other structures except the vertebral, except the vertebra. In all other aspects, it will be absolutely, or let's say, quite similar to the chance fracture injury. Now let's talk about the different parts of the spine injuries. McAfee classification, which we discussed before, can be used for any part of the spine. It can be used for thoracic part injuries, for the lumbar part injuries, and for the cervical part injuries as well. But as you remember, for the cervical part, we have two unique vertebrae. Unique, I mean anatomy of the first and second cervical vertebra is quite unique. So for the C1 vertebra, which we call atlas, we have separate classification, and as you can see on that slide, the fractures of the C1, we call it Jefferson fracture. It is a fracture of the anterior and posterior arc of the atlas. Here you can see anterior, and here you can see posterior arc. So both arcs, if the both arcs are damaged, we call it Jefferson fracture. Probably you hear about that type of injury. And we have minor classification for Jefferson fractures. We have so-called stable Jefferson injuries and unstable Jefferson injuries. Stable, it is injury of the anterior and posterior arc, but the transverse ligament still intact. Unstable, absolutely the same, anterior posterior arc plus rupture of the transverse ligament, which is fixed, as you remember, odontoid process of C2 of the axis. And in result, as you understand, that odontoid process can be shifted, can be displaced. And as a result, that odontoid process can compress the spinal cord at that level. It is very dangerous level if you talk about the spinal cord, because we have respiratory centers and cardiovascular centers, and compression of those of that area may lead to the death, immediate death of the patient. If you will talk about statistic, which one vertebra become damaged more commonly for cervical part, you will see that the most common location for cervical part injuries, it is C5, C6, no, C7, C5, C6, or probably most commonly seen fractures. And if you take a look to the thoracic part, you will find out that the most common location for wedge fractures, it is TH10, TH11 thoracic vertebrae. And if you will take a look to the lumbar part of the spine, you will see that the most common location of the fractures, it is L1, L2, first and second lumbar vertebrae. So why is like that? Why most common vertebrae which are become damaged located at the distal part of cervical spine, distal part of thoracic, and proximal part of the lumbar? I just try to find some picture of the spine in general. Okay, but I can't see it here. For better understanding why it's like that, we should try to remember what is it lordosis and kyphosis. As you remember, we have two physiological curvatures. We have physiological kyphosis. It is a curvature to the front, or curvature open to the front, which is open to the front. We have cervical lordosis, absolutely opposite, so cervical lordosis, it is a curvature which is open to the back. And we have lumbar lordosis, absolutely the same as the cervical part. It is a curvature which is open to the back as well. So what is the reason why we have physiological curvatures? The main idea, it is shock absorption. Our spine try to reduce loading during the jumping, when we stand in the vertical position, during the walking, sitting. And the best way how to do it, it is formation of the curvatures, like same principle as a spring. So when we jump, the angle of the lordosis and kyphosis increase, even not during the jumping, but during the landing. When we land to our legs, it will lead to the increasing of the loading to the different parts of the spine, and during that moment, angle of the kyphosis in the thoracic part and angle of the lordosis in the cervical and lumbar part increased. Increasing of the angle lead to the reducing of the loading, reducing of the forces. And as soon as the loading disappear, our vertebrae go back to the initial position. So the angle of the kyphosis and lordosis reduced. So increasing and reducing of the kyphosis and lordosis, it is a absolutely same mechanism as the spring work during the shock absorption. But in that spring we have few critical areas. Areas where kyphosis change to lordosis. It is an area where we have maximum accumulation forces. And if you will take a look, it is exactly C5, C6, it is exactly TH10 and 11 thoracic vertebrae, and L1, L2, first and second lumbar vertebrae. That is the explanation. That's why in most cases fractures happen at the areas where lordosis change to kyphosis and opposite. Okay, so let's return to first two cervical vertebrae. So once again, Jefferson fractures. That's are the fractures of the first cervical vertebra, and for the second cervical vertebra, we have so-called Hansman fracture. So for the second cervical vertebra, let's try to remember basic anatomy. Compared to the other vertebrae, for C2 we have unique odontoid process, which we doesn't have in other vertebrae. We have quite massive body below the odontoid process, and that unique connection in between the arc of C1 and odontoid process, which we have right here, help us to have a wide range of rotation. Our head rotation, in general, it is a movement in between arc of the C1 and odontoid process of C2. So, how we can classify fractures of the odontoid process of C2? Type 1 fracture. It is a partial minor injury of the odontoid process. When you have some fragment, not very big fragment, which is splitted from the odontoid process. Type 2 injury, type 2 fracture. It is a condition when we have complete splitting of the odontoid process from the vertebral body. And type 3 injury, it is a fracture of the odontoid process together with some fragment of the body. And how do you think, what is the most dangerous fracture? Type 1, type 2 or type 3? I can tell you that the most dangerous fracture it is type 2 injury. Why it's like that? If you have some minor injury like type 1, usually it doesn't achieve any compression of the spinal cord because the fragment is too small and it's still located very close to the initial position. If you have type 3 injury, take a look here, both bone fragments, odontoid process with a fragment of body and another part of vertebra become stuck. So once again, we doesn't have quite serious displacement in case of type 3 injury. If you have fracture of odontoid process only, what in that case you can expect displacement, especially if we have injury of the transverse ligament together with odontoid process fracture. So that is the most dangerous type of injury. Why we call it Handsman fracture? Quite interesting story. At the time of ancient Rome, hanging of the people, during the hanging of the people, rope knot was located on the lateral part of neck. And the reason of death during that procedure was asphyxia, as you understand. Asphyxia, it is quite scaring picture, quite scaring process, because the tongue came out from the mouth, eyes came out from the orbits, urination, defecation of the person, and so the picture in general is not very, very scary. So people from UK, ancient UK, they change the location of the knot. They shift the knot from the lateral side of the neck to the anterior part. And in result, as soon as supporting was removed, that knot, rope knot, press on the head of person, and it lead to very intensive, fast extension of the head. And in result of that extension, forced extension, most of the people achieve fracture of the odontoid process together with transverse ligament rupture. So that odontoid process, in result of fracture, displaced to the spinal cord direction, and that situation lead to compression of the centers, which I mentioned before, and immediate death of the patient in result of cardiovascular failure. That's why from that moment fractures of the C2, odontoid process of the C2, we call Handsman fracture. Clinical picture. If you will try to, if you will examine our patient at the accident place, for example, first of all, you'll find out muscle spasm at the affected area. It is a normal protective mechanism. If your patient will be consciousness, he will complain of intensive pain at some part of the spine, cervical, thoracic, or lumbar, depend from location of injury. Sometimes you will see neurological deficits like numbness or anesthesia at some part of the body or extremities. It can be weakness of some groups of the muscles. The patient will tell us that I'm unable to move my hand, for example, or I'm unable to move with my foot. In some cases, you'll find out that the patient have some problems with the respiration or cardiovascular system disorders. So principles, if you'll talk about the first medical help, principles still the same. ABC reanimation if it is necessary. You should open the respiratory organs, if it is blocked with I don't know, with blood or with a solid or with a vomiting mass. So provides normal respiration, restores the normal cardiac function if you have some disorders, and only after that you should provide first medical help for the injured part of the spine. First, it is of course shifting of the patient from the accident place to the ambulance or to the stretchers. And that shifting can be provided only by 3 persons. Not less than 3 persons can transfer the patient from the accident place, from the car, for example, to their hard surface. So second rule, you can use only hard surface scratchers or any hard surface. It can be door, for example, and you can't use soft supporting. Position of the patient, usually supine, so supine position on the hard surface. You can control breathing in that position, and your patient will have a minimal risk of bone fragments displacement if it's unstable fracture, for example. If it's a cervical pad injury, you can use special collar cuff. We call it shunts. By after, we call it shunts collar cuff, which you apply on the cervical pad. For the lumbar and thoracic part, just hard surface supine position. Future neurological and physical examination provided in the hospital. In the hospital, you can check reflexes, bulbar cavernous reflex. You can perform rectal examination. You can check other reflexes, knee joint, ankle joint reflexes, Achilles tendon reflexes. And if it is necessary, you will perform X-ray and CT scan or MRI, or both CT scan and MRI examination. I said if it is necessary. In most cases, it is absolutely necessary for best understanding of the disease, of the diagnosis. You should have not only X-ray examination results, you should have at least CT scan imaging. What is the difference between MRI and CT scan imaging? As you remember, CT scan, it is X-ray method, so we use gamma rays to achieve some picture, to achieve information, and as a result you will see better bones or parts of the body where we have high concentration of the metal, of the calcium. MRI will give you better picture of the tissue where we have high concentration of the water. So the ligaments, spinal cord, cerebrospinal fluid, internal organs will be better visible if you will perform MRI examination. Almost 50% of the patients who sustain spinal trauma have other associated injuries. You should remember about that, because spine trauma, if you will not talk about elderly patients with osteoporosis, for young people, spine trauma, it is a usual result of severe injury. Injury when the force was applied quite strong, which was applied to the patient was quite strong. And as a result, you should expect injury of the internal organs together with the spine trauma. It can be injury of the spleen, it can be injuries of the kidneys, it can be fracture of the pelvic, and other injuries and traumas. Head trauma, quite commonly associated with the spine injury. And you should remember that and examine if you have some clinical symptoms, if you will see some complaints, examine other organs as well. Patient management begins at the accident site, which I mentioned before, ABC reanimation if necessary, painkillers, opioids if your patient has severe pain to avoid traumatic shock development, shifting of the patient and immobilization on the hard surface in the supine position, or for cervical part, immobilization with a shunts collar cuff. So the patient management begins at the accident site. The key is to suspect spinal column injury in any patient who had multiple trauma. That is probably the most difficult thing. The most common spine injuries occur as a result of motor vehicle accident, high energy trauma, as I said before, falls, and sport injuries. These patients shouldn't be moved until the spine has been temporarily immobilized. Hard surface, supine position, that is immobilization for thoracic and lumbar part trauma. This is usually achieved with rigid spine board. A hard collar is usually carefully applied for the cervical part. Any turning or transferring of the patient must be done with gentle inline traction and long rolling. Line traction, it is a way how you can try to stabilize the bone fragment during the transporting. It's not only the key, it's not only the method which you should use for the patients only with the spine trauma, you should use it as well for the patients with the extremities fractures. So if you need to shift, if you need to move the hand or leg of the patient with fracture, just try to apply traction. As soon as you will perform traction, displacement in between the bone fragments at the area of the fracture will be minimal, and it will help you to reduce pain during the movement. Appropriate maintenance of the airway, breathing, and circulation must be initiated before future attention to the spine is given. No, treatment. Before we'll start to talk about the surgery and timing of the surgery, let's talk about the conservative management. Most common fractures, once again, that's wedge compression fractures. In most cases, not treated with the surgical methods. So, if your patient have stable, not complicated fracture of the spine, conservative management, it is a good option for the treatment. How we provide conservative treatment? Most simple way, it is straight bed regime. Just put your patient into the bed on the hard surface once again, and just keep your patient in that bed during few weeks, 2 to 3 weeks. In case of stable, once again, not complicated wedge fractures, in most cases that's enough. After that, we will use special belts, special fixators when the patient stand up and start to walk. So complete recovering of the vertebral bodies fractures will happen usually in 6 to 8 weeks. Depend from type of injury. If your patient have few wedge compression fractures, for example, in the thoracic part, sometimes 3, sometimes 4 vertebrae can be compressed. In that case, you may see the problem which we call hunch formation or hyperkyphosis formation, because in thoracic part we already have kyphosis. The angle of that kyphosis may become very, very acute, and in that case, that's not enough. Just wait until the healing will happen. In that case, you should try to reduce the angle of kyphosis, and you can do it by few methods. Most simple method, just put the sand bags under their thoracic part of the spine. You should start from a small bag, then change it to the bigger size. And we call that procedure as reclination procedure. So the angle of kyphosis day after day, as soon as you will change the size of the bag, will become less and less and less. But before you will start that procedure, reclination procedure, you should be absolutely sure that your patient have stable injury. Other way, that procedure may lead to quite serious neurological complication. Another way how we can achieve that reclination, it is traction through the Glisson loop, for example. When you apply that loop on the head and use a constant traction in the bed. So your patient have a constant traction of the cervical part through the Glisson loop. You can use a special belt for the pelvic area as well. So if your patient have injury, wedge compression injury of the lumbar part, you can apply special belt on the pelvic, connect that belt to the rope, and use some weight to achieve traction of the lumbar part of spine as well. But if your patient have complicated, if your patient have unstable injuries, it is a direct indication for surgical treatment. So timing of surgery. In the presence of progressive neurological deficitis, emergency decompression is indicated. Emergency does mean as soon as possible, but you can't wait more than 6 hours. In patients with complete spinal cord injuries or static incomplete spinal cord injuries, some authors advise or advocate delaying surgery for several days to allow resolution of cord edema. For neurologically normal patients with unstable spinal injuries and those whose with non-progressive neurological injuries, open reduction and internal fixation should be carried out as soon as possible. So, surgical treatment. First, in most patients, early open reduction and internal fixation are indicated to obtain stability and allow early functional rehabilitation. Cervical spine fractures may be stabilized with anterior, posterior, or combined approaches. If we will talk about the thoracic and lumbar part, in most cases we use posterior approach. Unstable injuries of the cervical spine with or without neurological deficit generally require operative treatment. Few basic principles. The injury must be early defined before surgery by plain X-ray examination, high-resolution CT scanning with a sagittal and coronal reconstruction, or MRI. Laminectomy has a limited role in the treatment of cervical fractures or dislocations and may contribute clinical instability and neurological deficit. Compression of the cervical cord or roots by retropulsed bone fragments or disc material usually is anterior. Therefore, anterior decompression and fusion with or without internal fixation are indicated. For posterior ligamentous or bone instability, posterior stabilization with the internal fixation and bone grafting are indicated. So, I just prepare a few clinical cases. So, let me show you a few examples. Here you can see burst fracture of the second lumbar vertebra with incomplete paraparesis 3 weeks after the injury. So here you can see how that fracture looks like on the X-ray. It is a CT scan image, but X-ray will give you absolutely the same picture. So as you can see, it is a burst fracture. We have a few fragments at the area of L2 body. And the most important is that fragment, that bone fragment, which you can see here on the CT scan. Once again, this one or this one. It is a clina urbana, so part of the vertebral body, fragment from the vertebral body, which is displaced inside the canal. That is a vertebral canal. And as you understand, compress the spinal cord or cauda equina, because it is the area where the spinal cord changed to the cauda equina at that level. So here you can see post-operative CT scan imaging. What that part of the bone, it is a fragment from iliac crest. So during the surgical procedure, it was done bone grafting we take the fragment of the iliac crest and perform transplantation to the area of vertebral body, so that fragment prevent future displacement of the small bone fragments from the body area inside the vertebral canal. So the size of the canal is completely restored, and I can tell you even more, it's become even bigger than it was initially. So spinal cord is completely released. Sagittal plan, you see that is a spinal cord, gray color tissue. It is a grafting fragment, it is a body, fragments of the vertebral body. So the canal is absolutely, the size of the canal is absolutely normal. Another example of compressive flexion injury in 20 years old woman with complete C5 quadriplegia. So the level of the fracture, as you can see here, it is a cervical part. So injuries of the cervical part always very, very dangerous, because if you have compression of the spinal cord at that level, it can lead to quadriplegia. Quadriplegia, it is total paralysis of the legs and hands, as you know. So here you can see CT scan image. That is a transverse foramen, it is a body, and as you can see, body is almost complete splitted from, not almost, it is complete splitted from the arc of vertebra. Plus, we have injury of the vertebral body as well. So, sorry. Here you can see that the fragment of the body is displaced, and here you can see that the body is displaced, is splitted from the arc. So both posterior and anterior complexes are damaged. So it is unstable injury. Unstable plus complicated. Quadriplegia, that means patient have total paralysis of the upper and lower extremities once again. So once again, fusion was achieved, grafting procedure, fusion in between C4, C5, C6 was achieved, and was done the surgical procedure of the spondylodesis with outer grafting. The shape of the canal was completely restored. Now I want to show you what else we can do except outer grafting procedures. What other types of implants which we can use for fixation, for stabilization. Here you can see anterior plating. It is a method when we put titanium or stainless steel plate on the anterior surfaces of vertebral bodies, and after that provide fixation of that plate with screws which we put inside the bodies. So the main idea when we usually do it, if you have a fracture of some vertebra, for example in our case C4, fourth cervical vertebra, you put screws into the C3 and C5. So you put screws in the vertebra above and vertebra below the damaged one. And as a result, the forces which we have transmitted, in that area transmitted from the body of C3 through the plate to the body of C5. And those forces avoided the damaged vertebra, avoided the C4 vertebra. Another method which we can use, it is so-called transpedicular screws fixation. And it looks like screws which you put through the pedicles of the vertebrae inside the bodies, and after that we connect the heads of the screws with the rods, no, titanium once again or stainless steel rods. So main idea, make a frame which will hold two vertebrae together, or same principle as with the plate, we can put screws into the vertebra above the damaged one, and we can put the screws in the vertebra below the damaged one. So the forces will be transmitted along the implant and avoid the damaged vertebra. But transpedicular screws in most cases very popular for the fixation of the thoracic and lumbar part of the spine. For the cervical part, it is not common method of the treatment. Why? Let me show you why it's like that. No, let's take a look here on that image. Take a look how we put the transpedicular screws. The direction is like this. So we put it from the back to front through the joint inside or near to the joint, through the pedicles inside the vertebral body. And take a look, if the direction of implantation will be improper, if it will be too lateral, then you will damage the vertebral artery, which is located at the area of transverse foramen. If you will put it too middle, you will damage the spinal nerve, which is located right here at the lateral part of the vertebral canal, and then left the canal through the intervertebral foramen. So it should be very precise, very clear procedure, and you doesn't have any chances for mistake. For lumbar part and for the thoracic part, we doesn't have transverse foramen and we doesn't have vertebral arteries. So the risk of those structures injuries is absent. That's why most of the surgeons for the cervical part prefer to use anterior approach and plating, and for thoracic part and lumbar part, posterior approach and transpedicular screw fixation. And last example, you see, it is injury when we have almost, no, not almost, a complete displacement or complete dislocation of the vertebra. So that is the vertebral body of the proximal part, and it is the vertebral body of the distal one. Here we have a spinal cord. You can imagine what happened with that spinal cord. It is completely damaged. That is the MRI picture of the same patient. Brain, spinal cord, and area of the trauma. So the spinal cord completely damaged, completely compressed by the displaced vertebra. Of course, you should expect quadriplegia in that case, and neurological complications, usually irreversible. And few words about the odontoid process fixation. Here on that slide, you see that main idea, it is a screws fixation through the body into the odontoid process itself. The approach usually provided through the mouth. You need you need X-ray navigation in the operating set, a C-arm, and initially doctor just put two wires inside the odontoid process, and then doctor will use cannulated screws. Cannulated screws, that means that you have a hole inside the screw, and you can put that screw through the wire which you already insert inside the odontoid process. We need it to avoid injury of the organs which are located around odontoid spinal cord, of course, first of all. So wires, it is your guide, and as soon as you put your guide where it should be, only after that you will insert the screws inside. Так, it is already 5. It is already 5, да? So probably we will finish. Do you have any questions, colleagues? Please write down the questions. I have 2 minutes. If you have questions, I will try to answer. So no questions, as I understand. Okay, in that case, thank you for your attention. Goodbye.